Hi, my name is Debbie Teodorescu. I'm a physician at Mass General Hospital, and I'm here to talk about what to do in the case of decompensation in the ward patient of COVID-19. Relevant disclosures: all content is for informational and educational purposes only, and all opinions expressed are mine alone based on my experiences. Back to talking about a 30-year-old gentleman with no past medical history who is here with 5 days of progressive non-productive cough and dyspnea, and who was admitted to the ward under excellent care. The vast majority of the time, statistically, the patient will recover just fine with some supportive care, but we want to always plan ahead just in case things don't go as planned. And what is it that makes patients with COVID-19 fail floor level of care? There's all sorts of things, right, that we've been discovering over the past few months. Sepsis, severe encephalopathy, thrombosis of every organ, sudden cardiogenic shock, things of that sort. But the vast majority of the time, failure in COVID-19 is driven by respiratory failure. So that's going to be our focus of discussion. The watcher flags, again, I cannot state enough. You can have O2 requirement changes being your watcher flag, or it can also be just plain work of breathing without changes in oxygenation. Other things like mental status, symptom burden, things like that are pretty non-trivial, and we do take those very seriously as well. We recognize as well that COVID-19 on average, when people do poorly, they tend to slip over the course of multiple shifts. It's rarer, not at all unheard of, but a little rarer for people to slip over the course of minutes to hours. So when that happens, I would very strongly start to think about, are there any alternatives that I am missing, or any good explanations I need to be keeping in mind? So rule number one is ensuring that you, your team, everybody is able to stay safe. So keeping in mind what level of oxygen is on the floor, both for the patient's sake and also to reduce the risk of aerosolizing viral particles into the air. And remembering that anything that we take normally for granted as a rescue therapy, bag valve masking, intubation, CPR, all of those things require staff that need to don PPE and to prepare. So it's safer for everybody to plan ahead, to stay 2 steps ahead of game, to overplan. No one will be too upset, hopefully, if you do overplan a little bit, as long as you stay safe and the patient stays safe. So out of a systematic way of dealing with decompensation, let's go step by step, shall we? Step number one is to temporize. Buy yourself time so that you can discuss with the patient and you can figure out what's going on, and you can try to treat them and to reverse their decompensation. You want to try to encourage them to prone. As we're discussing the proning, if they're really hypoxic, this is probably not the time to prone for the first time. Not because proning is inherently that unsafe, but because sometimes with these patients, even the act of sitting up or shifting side to side is so exertional that they desat. So if they're already half a liter of O2 away from needing intubation, potentially, this is not the time to find out that they've been in that category. By contrast, if you know they've tolerated deep proning before, this is an amazing tool to be able to deploy. And that's helped for a lot of my patients before actually bringing them back from the edge. I've increasingly deployed non-rebreather masks early because they're more comfortable for the patient. 10 liters of nasal cannula feels like a blast in the nose, whereas 10 liters from a non-rebreather feels like a generous breeze on the face. So much more tolerable. And at the same time realizing there's always a temptation, right? Like there's sometimes in the 70s, but more often they're 86, 87. Oh, maybe we'll get them above safety threshold if we just turn up their O2 by 1 or 2 liters. And by the time you're at 10 liters, that 10-liter mark looks awfully close to the 15. So how big of a difference is it to turn up my nasal cannula up to 15 liters? But that's really when you start to get aerosolization risks. So non-rebreather mask early is good for the patient and good for you. Minimal movement can worsen, so really trying to ensure they have bedpans and urinals, especially if you're going to diurese them. This is not the time to find out that not only does proning cause them to desat, but also sitting over the edge of the bed to urinate also makes them desat. So trying to make sure that you can support them as best they can. Some parts of this are controversial, so let me dice this out very carefully. There is no excuse to skip the first 3 steps. Making sure they have oxygen, cannula, or oxygen device properly applied, ensuring you have good vitals and work of breathing assessment, and also ensuring that you have a proper mental status, things that your extended care team can be very helpful with, that you can do from the door. You can also do at the patient's bedside, or even through telemonitoring. I've been very surprised at the number of times when oxygen loosened along one of the numerous connectors, whether it fell off the wall outlet or along the way, fell off the device itself, nasal prong is out of place. Lots of different ways that O2 can misbehave. So good for you to personally ensure that it's working. I personally am a big believer that nothing beats actual patient presence at bedside, both to calm the patient and also to figure out what's going on. But this has to be balanced, of course, against the realities of conserving PPE as well as protecting the greater staff. So I would say if you do have the opportunity to do an exam, the high yield aspects are things that speak to the cardiopulmonary status of your patient. And I would say that in the same way that neither the exam does not tend to affect what you would do for your first therapeutic options, so too do diagnostics not affect it. This is not true, of course, with folks with more rapid decompensation who have an alternative diagnosis. I would say that these are often the first steps. I would point out that I've very, very rarely actually gotten CTPs. First, because if they're only developing decompensation from a respiratory standpoint, getting PE treatment started now as opposed to 30 minutes later isn't going to make a big difference. Unlike if there's hemodynamic shifts, that's a big different story. The other is there's a high risk of infection control problems as you're getting to the scanner, or they're decompensating even worse and then needing to intubate in the scanner, which would be an absolute nightmare. So just my 2 cents, of course, but it depends on the clinical situation in front of you. All in all, though, whether exam or diagnostic, you pretty much would do the same thing in the absence of any obvious contraindications. In addition to the things that Ben has talked to you about for therapeutics, we want to consider, first off, a dose of loop diuretic. I know we care a lot about renal effects of COVID-19. This is not the time to be gentle when a patient is in respiratory failure. And I would say a patient has not failed a loop diuretic from a respiratory standpoint until they've peed more than 200 cc's an hour and are still hypoxic. If you push 20 of IV Lasix, they haven't peed, that doesn't mean they failed. That just means you haven't found their dose yet. If you push 20 of IV Lasix and they urinate tiny drops and they're still hypoxic, doesn't mean they failed. If you've pushed 20 of IV Lasix and they've urinated 600 cc's and they're still hypoxic and not getting better, then yeah, they failed. So that's important to keep that distinction in mind. And getting inhaled bronchodilators, even if they have no COPD or asthma history, COVID-19 is incredibly bronchospastic for some patients, so that's very helpful. If you're able to get chest PT, especially if they're already prone anyway, they're already in a good drainage position, so chest PT, to whatever extent you're able to perform it or have your staff perform it, can be incredibly helpful as well. And then sometimes controlling supraventricular tachycardia, especially in those patients who have a baseline AFib. I know some of the time it's hard to tell if it's reactive versus it's driving the problem, but it's often a vicious cycle that we want to break, because otherwise flash pulmonary edema is very challenging to deal with on top of everything else. And so actually the chances are quite good that with these 4 steps, you will have managed to stabilize your patient. Our 30-year-old gentleman is now breathing better on 6 liters of O2 after urinating and getting the breathing treatments. So what do we do next? We don't rest on our laurels. Whether or not they've improved, whether they've not improved, we see it as, we don't know if this is just their one bump in the road or if they're going to wind up having more trouble in a few hours. Regardless, this is a fine time to update any family members or healthcare proxies if the patient wants to, preferably via video call. Getting any language assistance throughout this briefing time is very useful. But it's really trying to ensure that the patient is as comfortable as possible when you're having this conversation. It's really critical that ensure that patients are reassured that you've got their backs. And of course, on the flip side, if they're not improving, it's important to engage extra resources early. So whether it's ICU or transfer outwards. You want to make sure you're having everything that you need to ensure that you're staying safe, your staff stays safe, and above all, your patients stay safe. So thank you very much, and stay safe out there.